Okay, are you all able to see? So, yeah. Right, narrow roots L2 to S2. The lumbosacral plexus has got upper plexus L2, L3, L4.
So we can't see the screen.
Can't see the screen? Okay, then I think there is some problem here. Today there is a lot of electricity problem here. So, and I'll try and share it again. Okay, so. Are you able to see now?
Yes, sir.
Yeah, okay, right. I think we are set. So upper plexus and lower plexus will be L1, L2, 3, 4 and L5, S1, 2. So far the symmetry is maintained when to learn up to this point. But then each plexus we can study by lumbar plexus and sacral plexus. So first we'll think about L2, 3, 4. L2, 3, 4 can be anterior divisions. That, as I said, roots, divisions, and nerves. So anterior divisions and posterior divisions. You can see the anterior division nerves that are coming. These are usually obturator nerve and so accessory obturator nerve. The posterior divisions have from L to 3 have lateral femoral cutaneous nerve, and of course, most important is the femoral nerve. The division of lower plexus, as I said earlier, that is L4, L5, S1, S2, S3, 4 will be the second part. So L2, 3, 4 unit, a branch of anterior division of L4 will join the L5. And again, the distribution is anterior and posterior division. So roots, divisions, and nerves. You can see the fibular division and the tibial division. Tibial division is from the anterior portion of the L5, S1, S2, and the posterior division has got the fibular division, and you have the two important nerves here, superior gluteal nerve and inferior gluteal nerve. These are called root collateral nerves because if there is weakness in the distribution of these nerve distributed muscles, then you can say that it's a root pathology, not the nerve pathology. We'll again discuss it later. So upper plexus L2, 3, that is posterior division, lateral femoral cutaneous nerve of thigh, which causes meralgia paresthetica, and the femoral nerve, which supplies the iliopectineus muscle, sartorius, and ends as the saphenous nerve. And the anterior division will give rise to obturator nerve. So these are the main nerves that are coming from the upper plexus. And Abhi, are you able to see? Somebody said not able to see the screen. Are you able to see?
Yes, sir.
Yeah, okay. Next. The femoral nerve, I can remember it as Q-tips. That is, it supplies the quadriceps femoris muscle, rectus femoris, sartorius, and the articularis genu. These are the important muscles. So its main function will be in the flexion of the hip as well as extension of the knee. Femoral nerve is responsible for hip flexion and knee extension, supplies quadriceps femoris, articularis genu, iliopsoas, pectineus, and sartorius. It terminates as saphenous nerve, which supplies the medial aspect of the leg. The L4 branch to the lower plexus includes sciatic innervation of adductor magnus muscle. And the other muscles, others divisions are the obturator nerve to adductors. So that finishes with upper plexus review of anatomy. And the obturator nerve, which supplies the adductor longus, adductor brevis, and adductor magnus, which has got dual supply. Sciatic nerve also supplies this part, adductor magnus, that fulcral nerve. Mononeuropathy is rare and manifests as thigh adduction weakness. If there is no history of trauma or cancer, then usually it is radiculopathy. So the important point to note is for plexopathies, there are only two causes. Either it is trauma or infiltration of the cancer cells. PIVD is rare, rostral to L5. So whatever PIVD is, will be L5, S1. So postal to L5, we have to think of infectious or inflammatory causes that come into picture. So the lower plexus divisions are the fibular division and the tibial division, and the root collateral nerves that are coming from L4, L5, and S1. The L5 is in superior gluteal nerve, which supplies the gluteus medius, and the inferior gluteal, gluteus maximus muscle. So this has got abduction is superior gluteal nerve, and hip extension is inferior gluteal nerve. If you are able to examine these two, then there will be you will be able to differentiate from the root pathology from the nerve pathology. So superior gluteal nerve, gluteus medius and tensor fasciae lata, inferior gluteal nerve, gluteus maximus. The sciatic nerve supplies adductor magnus, posterior thigh muscles, and all muscles distal to knee. The posterior thigh muscles, semitendinosus, semimembranosus, biceps femoris, and distal is that all the tibialis anterior, tibialis posterior, peroneus longus, peroneus brevis, all the flexor hallucis longus, flexor digitorum, extensor hallucis, extensor digitorum, all these muscles are supplied by the sciatic nerve. See, the branch to adductor magnus and the tibial division and fibular division. The fibular division, before enters the knee, it supplies the short head of biceps. So if you want to localize, you should be able to do an EMG on short head of biceps. Lumbosacral plexus, proximal motor nerves, the importance. The superior gluteal nerve and the inferior gluteal nerve originate proximal to sciatic nerve origin. And these supply gluteus medius and gluteus maximus, which are important muscles. Their involvement disapproves a sciatic neuropathy. So if you are able to demonstrate abduction weakness or hip flex extension weakness, then it is not at all sciatic neuropathy. Though sciatica is attributed to sciatic neuropathy, it's rarely a cause for the back pain. Back pain is usually caused by S1 radiculopathy. The sciatic nerve in thigh is branched to adductor magnus, divides in tibial and fibular divisions. The fibular division is earlier called as common peroneal. The tibial nerve supplies posterior leg and all the non-extensor intrinsic muscles and terminates as a sensory digital branches in the foot. The fibular nerve causes the foot everters. So these are the nerves that you can see in the diagram. And the most important is the tibial nerve, which into lateral plantar nerve, medial plantar nerve. And sometimes we may have to inject into these muscles also whenever they are involved in the spasticity. So we should become knowledgeable about these muscles. The fibular nerve, the superficial fibular nerve, that is superficial peroneal earlier, is causes the foot everters. That is peroneus longus and peroneus brevis. And also sensation over the dorsum of the foot. The other hand, the deep fibular nerve causes that is the foot dorsiflexors, and usually that is L4, tibialis anterior. Sensation over the skin between the great toe and second toe. May I request to unmute, please? Yeah. Mute. So after we considering these two nerves, then we go on to the lumbosacral plexus disorders. Basic idea is in the interactive session also, we have to differentiate between mononeuropathy from radiculopathy and from plexopathy whenever we are encountering a clinical problem. So roots divides directly to form nerves here. As I said earlier, it could be monomelic. Just imagine whether the The involvement is in one limb or more than one limb. So as I said earlier, monomelic is mononeuropathy, plexopathy, and radiculopathy. And polymelic, if you can look at the differential diagnosis, it can be pure motor, it can be pure sensory, and it could be mixed. The mixed is mostly because of polyneuropathies. If it is pure sensory, then you have to think of polyganglionopathies or pure sensory neuronopathies, usually by and large secondary to malignancy or pre-malignant syndrome or paraneoplastic syndromes. In the lower limb, pure motor are three causes. One is amyotrophic lateral sclerosis, neuromuscular junction disorder, or a type of myopathy. So the pure motor in the lower limbs, pure sense lower limbs, polymelic, you can differentiate clearly. So if you look at the patterns that disapprove mononeuropathy, suppose you got a hip flexion weakness and adduction weakness. Hip flexion is by femoral nerve, which is L3 root value, and the adduction weakness is because of obturator nerve, which is L4 value. So if you have both these, it can never be mononeuropathy. It should be radiculopathy only. Similarly, another combination is weakness of foot inversion and eversion. If you look at the inversion, it is caused by tibialis posterior, which is L4. Eversion is by peroneus longus and brevis, that is S1. The third combination which you have to remember is weakness of a limb muscle and gluteal muscle. As I said earlier, gluteus medius is L5, that is abduction of the thigh, and gluteus maximus is extension S1. So for the learner's sake, I'll tell how to examine in the younger generation. We'll show a couple of slides. So radiculopathies, and see, most important in lower limb is a foot drop. Foot drop, they are more common below L4. So foot drop can be proximal lower extremity weakness is not usually due to radiculopathy. So proximal lower extremity weakness is not likely radiculopathic. The foot drop may result from two causes. Though there are other causes, importantly, L5 radiculopathy you have to differentiate from peripheral neuropathy. The other cause for foot drop could be ALS. ALS also can cause foot drop. And similarly, you have to differentiate S1 radiculopathy from sciatic neuropathy. Here, your gluteal muscle weakness, and that if you assess, and it should not be observed in sciatic neuropathy, but because it's because of the root collateral now. The mononeuropathies are less common, but you can come across only femoral neuropathy and lateral femoral cutaneous nerve of thigh. And you may have entrapment neuropathy or pressure pulse of common peroneal nerve also, but they are uncommon. See, these are the some thumb rules of lumbosacral plexus, which we tried demonstrating. If you look at the differential diagnosis, the heart vintages, you can see hereditary, occupational, trauma, vascular, infectious, neoplastic, toxic, metabolic, autoimmune, gender-related. Electric events means that is loss of conduction, that is demyelination mostly, and secondary effects, that is bystander effects and infiltration because of the neoplastic process. So the broad, how do you, but out of all these, we have some very acute presentations. This is trauma, the evident on history. Vascular, it is ischemia, hemorrhage. May I request you to please mute yourself, please. Electrical events, they are loss of conduction, demyelination. So these are the important acute categories. These are the three acute categories you have to remember. What laboratory investigations? Mostly EMG, NCV, and ultrasound. If you think of mononeuropathy, if you think of plexopathy, CT, MRI, except in diabetics. If you think of radiculopathy, CT, MRI, and LP, if infectious and inflammatory or immune process suspected. So these are the broad investigations which we usually undertake. So you look at the radiculopathy. The CMAP remains normal as muscle receives tweaks from the other neurons. So this is the compound muscle action potentials. In radiculopathies, it won't show any change. And also the SNAP is preserved. The radiculopathy is proximal to the dorsal root ganglion. So that is a problem here. So the SNAP is preserved. The CMAP may not reduce in amplitude, but F wave may be prolonged. So the plexopathy, on the other hand, will cut distal to the dorsal root ganglion. As you can see, distal to the dorsal root ganglion. So here, initially SNAP may be preserved. Subsequently, SNAP is not seen. It gets affected. The sensory nerve action potential loses its height, as you can see, and the motor neuron or the CMAP may remain preserved for some time. So if there is the most important is SNAPs, whether they are involved or not, and also F wave, and we can take help of H reflex also in the lower limbs. The plexopathy, after some time, you can see the sensory neuron will go and it will disappear, but motor neuron may be present for some time. On the other hand, if you are the anterior horn cells, the anterior horn cells will show no abnormality. Everything is preserved. Anterior root, the posterior root, the spinal nerve, the posterior ramus, the anterior ramus. Only the gray matter in the anterior horn cell is affected. So you may have some neurogenic pattern with giant action potentials on EMG, but you may not have much of change in the CMAP or sensory nerve action potentials in anterior horn cell disorders. So let us look at the nerve root lesions. All motor fibers are distal to anterior horn cells. They are affected. So paraspinal muscle EMG is abnormal. There may be truncal and proximal muscles are involved, and limb muscles are also involved. So dorsal root ganglion and distal sensory nerves are intact. The stimulation of the limb sensory nerve results in a normal SNAP or sensory nerve action potentials. The moment you see normal SNAP and abnormal CMAP, you can conclude that it could be nerve root lesion. So root lesions, no effect on SNAP because pathology is proximal to dorsal root ganglion. The plexus lesions, there will be always abnormal SNAPs. There nerve lesions, abnormal SNAPs in one nerve territory only. Denervation of paraspinal muscles is possible in root lesions on EMG, whereas they are unaffected in the plexus lesions, and muscles affected in one nerve territory only if there are nerve lesions. These are the common findings on electrophysiology. Let's look at the L5 root, which is very important to master it. The superior gluteal nerve supplies gluteus medius, and gluteus medius does abduction of the thigh, and also tensor fasciae latae and gluteus minimus. The S1 root is inferior gluteal nerve, that is gluteus maximus, and it is also mediates the H reflex, which you can see down below here. It stimulated the tibial nerve at knee, and the record is done over the gastrocnemius and soleus complex. Abnormal H reflex indicates pathology in the sensory afferent portion, intraspinal portion. Kishore class lo nana mattu maatade. Dorsal root, abnormal H reflex indicates pathology in the sensory afferent portion, intraspinal portion, or motor efferent portion of the reflex arc. It does not localize pathology to S1 nerve root. So let us look at the L24 lumbar plexus. So let's look at the L24 lumbar plexus, L5 sacral plexus, S1 sacral plexus, and three angles: motor, sensory, and reflexes. The important muscles to concentrate on L24 is iliacus, that is hip flexion, knee extension, and of course adductor longus, that is obturator, that is adduction. And the sensory part, anterior part of the thigh, knee, and medial calf. Medial calf because of the saphenous nerve, that is distribution on L4 dermatome. L4 dermatome and saphenous nerve, they are onto the, and the reflexes are patellar reflex or knee jerk. L5 sacral plexus, and look at reflex. There is no reliable L5 reflex, but ankle jerk is S1 and 2. So L5 we don't have a reflex, but the muscle supplies are supplied are tibialis anterior, that is the and posterior tibial, tibialis posterior, peroneus longus, gluteus medius, and hamstrings, peroneal and tibial. And of course, the sensory is lateral leg and dorsum of the foot. The S1 is gastrocnemius, gluteus maximus, hamstrings, and that is peroneal nerve and tibial. Both supply this. The posterior leg and plantar foot, and the reflexes or the ankle jerk. So for L5, there is no reflex. S1, 2, we have a reflex. L2, 3, 4, we have a reflex to L-sit. So these are some of the important diagrams which we have to remember how you do in this is the abduction of the thigh. For the inferior gluteal nerve test, that is L4, L5, the gluteus medius, the hip abduction with the patient in lateral decubitus position, you can test like this. The tibialis anterior is the dorsiflexion, deep peroneal nerve, and you can see the dorsiflexion, how it can be tested for tibialis anterior, which we usually do in EMG also, and sometimes we inject botulinum toxin. The peroneus longus and brevis are superficial peroneal nerve, and these are everters. Usually peroneus brevis and peroneus longus, you can see these are the two nerves. The posterior tibial nerve, that foot inversion, tibial, that is inversion is seen here in the lower part. So this is the inversion of the tibialis posterior muscle. So these are the important tests which you have to do in the lower limbs. And some more we can show that sciatic nerve and hamstrings, knee resisted flexion with patient supine and thigh flexed. This is the sciatic nerve function. You are testing semitendinosus, semimembranosus, biceps femoris. What you are testing is flexion of the knee. S1 root, what we do? S1, we have to test the hip extension, that is gluteus maximus, which is supplied by inferior gluteal nerve. And you see tibial nerve, another function is gastrocnemius, that is foot plantar flexion. You can see the plantar flexion testing. And to detect the slight weakness, patient should be asked to stand on one foot, raise the heel from the ground, and maintain this position. So normally what we do is ask them to walk on heel or forefoot. Then you can easily detect whether there is any weakness or not. And so, of course, reflex testing, as you can I want to revise that. The knee jerk is the femoral nerve, L to 4, and please don't say L5 any time. This is ankle jerk is S1 and S2 sacral plexus. So that's the sensory part we have to see. This is the sensory part, and you can see the anterior part of the thigh is L2, 3, and concentrate on the medial aspect of the leg, which is L4. And L5 is the interdigital space from the great toe on the second toe and the lateral aspect of the leg, so which is the sensory dermatomes of the lumbosacral plexus, which you can remember. And most importantly, where is L4, where is L2, where is L3, and where is L5? You can see the L2, L3, L4, L5. Just remember them, and to master this, you have to know. If it is a lumbar plexus, you can have many nerves that are involved. Lumbosacral plexus. So there's still a lot of noise coming in the background. Okay, so lumbosacral radiculopathy. So we have to learn radiculopathy, plexopathy, and mononeuropathy. What is the most characteristic features of radiculopathy? Back pain, radiating pain down the leg. There will be numbness, tingling, sensory loss in the involved dermatomes. That's why you should know what is the dermatome. There is weakness in the involved myotomes. Because the muscles are usually innervated by neighboring nerves also, you may not have profound weakness in the muscle as you see in the nerve distribution weakness. And so we also have to learn in this region about conus medullaris and cauda equina a bit, which we'll see. So these are the L2, L3, L4. Then lesions, if you are there, You can have the sensory distribution, the lateral cutaneous femoral cutaneous nerve, that is meralgia parasthetica. Right. So that is the now Carda equina syndrome. What is Carda equina syndrome? Usually it is chronic. Just remember that it is asymmetric and chronic. Carda equina is very rarely acute, but usually it presents by chronic pain with wasting in one limb, and there will be reflex loss. There will be bowel and bladder dysfunction and sexual dysfunction, which is later. The saddle anesthesia in cases of carda equina is asymmetric. It's not symmetric as shown here. So it can involve bilateral lumbosacral radiculopathies, but in a asymmetric fashion, that is carda equina syndrome, which is seen secondary to lumbar canal stenosis with multiple disc prolapses. So that's a carda equina syndrome. On the other hand, if you are to look at the conus medullaris, usually there may be UMN findings. There's not much of a weakness in this, but there is a gross saddle anesthesia with the pain is less in this case. It's symmetrical, and right from beginning you have bowel and bladder dysfunction. The symmetrical involvement of saddle anesthesia, some UMN findings, less painful condition, involvement of bowel and bladder right from beginning is characteristic of conus medullaris. Now we go to the lumbosacral plexopathies. And one of them important causes for this is plexopathy, as I said, is either neoplastic, and that be secondary to carcinoma, cancer cell infiltrations, or radiation therapy, or it could be because of trauma, that could be obstetrical and gynecological lesions and operations, and sometimes you get intravascular injections and also intramuscular injections in the buttock. We can cause vasospasm and retroperitoneal hemorrhage. A patient who is on heparin can develop retroperitoneal hemorrhage and develop lumbosacral plexopathies. So lumbosacral roots and plexus lesions, you can see which I think I'm not going to spend much time on this. We'll switch gears. So now let us look at the L24 nerve roots, lumbar plexus, and motor testing. What you have to do, this is the hip flexion that is being tested, which is because iliopectineus muscle, which is mostly L2, L3, that is the femoral nerve function. And you can see the extension of the knee. That's also again, knee extension is the femoral nerve. And you can see abduction and adduction. Adduction is adductors, the obturator nerve. That is the L234, the hip adduction, knee extension, hip flexion. These are three common things which you have to remember for this particular L2, the testing of these muscles. Then L5 nerve root and sacral plexus. So that is, again, you can see the hip abduction. You have to master this technique of hip abduction. This is the hip extension, and of course, inversion and eversion.
Cutting
When
చేపించుకున్నావా?
the patient comes with a foot drop, the most important test what you have to do is inversion and eversion test. So inversion and eversion is very important in this case. So inversion is by tibialis posterior muscle, and so that if inversion is also found weak along with eversion, it is no more a peroneal nerve problem. It is a L5 radiculopathy. So that's an important thing. That's an important point which we have to learn about this particular aspect here. And now we'll go on to the S1 nerve root. S1 nerve root, as I said, is hip extension supplied by gluteus maximus, inferior gluteal nerve, S1. So hip extension, if it is weak, it is no more a neuropathy. It is a radiculopathy. And also you can see the plantar flexion, which is by the gastrocnemius and soleus muscles, right? That again, L5, S1. So these are the important tests which you have to learn to do quickly in your bedside OPD. So reflex testing, and to reiterate, the patellar is L24, lumbar plexus and femoral nerve. The Achilles, so there is the ankle jerk is S1, 2, the sacral plexus, sciatic nerve and tibial nerve. But problem is there is no L5, which you should remember very well. The radiculopathy, as I said, back pain, radiating pain down the leg, numbness, tingling, sensory loss in the involved dermatomes. Again, I just put the slide so that you remember all the dermatomes. And most important is L4. L4 is the medial aspect of the leg. And L5 is the web space between the great toe and the second toe. And S1 is the lateral aspect of the foot. And L5 is the lateral aspect of the leg. L2, 3 is the anterior aspect. So these are dermatomes and which are very important. So summary and EMG and CV, please write down all the abnormalities which we have to test. What are the sensory nerve conduction studies show? What does motor nerve conduction studies show? What is F? What is H? So we may have to see a bit of these. And in cases when you have suspicion that is an entrapment, then you have to do inching studies, then the needle EMG. So history and physical examination leads to hypothetical localization initially. The likely anatomical localization confirmed by EMG and NCV. We'll see briefly about these aspects. SNAP abnormalities are distal to the dorsal root ganglia. So SNAPs, if they are elicitable, the problem is proximal to DRG towards the spine. CMAP abnormality should be tested with needle EMG. If you look at why EMG is very important is in nerve conduction studies, we are only testing common peroneal and posterior tibial, but we are not at all testing the proximal L2, 3, 4. So EMG is very important in lower limb. If you do only nerve conduction of posterior tibial and common peroneal or fibular nerve, that's not sufficient. The anatomical localization depends on CMAP, SNAPs, F, NCV, and H reflexes. So all these things are to be taken into consideration. So let's have this discussion on this. A 68-year-old man with hypertension, anhedonia, and COPD, he had got pain in the lower extremity followed by foot drop, left side foot dorsiflexion, and inversion weakness. There is absent ankle reflex with decreased vibration from the ankles distally bilaterally. There is a recent onset of left foot drop with weakness of the left foot dorsiflexion and inversion also. So where is the problem? Is the localization. Got a foot drop. Is it a left tibial nerve, left common peroneal nerve, left lower lumbosacral plexus, or left L5 nerve root? Which could be the answer in this case? So somebody has to talk. Yeah. You can see, you can unmute and tell also. Any answers which are coming out? B, wrong. A, wrong. So it's not these two. So we'll have to go to the answer to see. See, why it is not, we'll have a discussion. Foot dorsiflexion can be peroneal nerve. And the inversion is tibial nerve. So mononeuropathy and radiculopathy or plexopathy it can have. By thumb rule, we rule out mononeuropathy because of rarity. As I said, only femoral and lateral femoral cutaneous nerves in lower limb cause mononeuropathies. Plexopathies are also usually secondary to trauma and cancer, which is not the case here. So most probably it is L5 radiculopathy. So if you look at the motor, sensory, and reflex findings in the differential diagnosis, weakness in one nerve is territory is not there. Weakness in more than one nerve territory suggests either plexopathy or radiculopathy because there is no history of any trauma. So it is not. Most common cause of more than one neuropathy is radiculopathy. It may be combined with plexopathy in severe trauma and diabetes, as you see in diabetic amyotrophy. As I said, plexopathies are rare. हाँ प्रणव बोलो. हाँ बोलो. गुड नहीं क्लास चल रहा है क्लास चल रहा है. ओके क्लास चल रहा है प्रणव. ओके so second question, patient presents with right lower extremity weakness. There is weakness of right foot dorsiflexion, inversion and eversion. There is no history of trauma or cancer. So now can you identify what is the cause? Is it mononeuropathy, plexopathy, radiculopathy? Yeah, everybody knows. I've been telling. C. Okay. It's a radiculopathy. Just remember that the weakness in the inversion is tibialis posterior, eversion is peroneus. That is, so both L5 and S1 are involved. So the answer is very simple. A patient reports right lower extremity weakness. On examination, is found to have foot dorsiflexion eversion weakness. Is likely to have plexopathy or fibular neuropathy. Simple. Yeah, that's correct. You can unmute and say, here it is fibular neuropathy. Yes, it's only eversion weakness. Right. So we need to do the possibilities of right femoral neuropathy or upper lumbar plexus. You have to decide. You have to do nerve conduction studies and EMGs. So we'll be briefly discussing these aspects also in this. The sensory nerve action potentials are very important in the lower limb. And the SNAP requires three structures to function properly. That is a myelin sheath, the vasa nervorum, the axon. So it's difficult to usually uh, quantify the amplitude of the sensory nerve action potentials because the fibers are dispersed. They're sometimes variable in number. But even there are few numbers, the sensory nerve conduction takes place. So the muscle contract. So we will not be able to really quantify. That's why it's very important to see whether you get a snap or not. Second one, the other one is CMAP. It requires the following structures: myelin sheath,
తిన్నావా
axon, vasa nervorum, motor nerve end plate, neuromuscular junction, muscle. Please mute, please. Mute, please. Now look at the F wave. The F wave is the most important aspect which we get. This is a F wave which you can see, and which is often prolonged and demyelinating neuropathies. Then you are giving a stimulus, and that stimulus will go to the axon. It travels and comes back to the muscle. And depending on the frequencies, please mute yourself, please. So now there comes the F reflex and H reflex. The H reflex, you can see, you can stimulate the antrodromic motor activation takes place and the orthodromic motor activation takes place. So it has to go to anti-horn cell and comes back to the dorsal root ganglion. This is soleus muscle. So this arc usually the H reflex, you can see the H and the M wave and the artifact, that is the stimulation artifact and the small CMAP and the H. So this particular thing tests the S1 root. It has got both sensory, intraspinal, and the motor complex. The third aspect which I said is muscle at rest and muscle with voluntary contraction. You have to see in EMG, what we do is we test four aspects. First is insertional activity.
సరే వెళ్ళు. ఇంటి ముందు తుడిచావా
ఇంకొకరేమో నీళ్ళలో మరి ఇంకొకడు ఎక్కడ ఉంటాడు
Yeah. So I said four aspects which you have to mention: insertional activity, spontaneous activity, motor unit action potential, and fourth one is either recruitment or interference pattern. So these are the four important things. And some you have to see muscle at total rest, muscle with voluntary contraction. So some of the aspects of EMG are very important. You have to practice. Abnormal snaps, if you look at one nerve territory only. EMG abnormalities are restricted to one nerve in mononeuropathy. Abnormal late response are limited to one nerve only. And paraspinal EMG is normal. So these are the nuances of mononeuropathy on the EMG. Right. Plexopathy, abnormal snaps, as I said earlier, variable abnormal late responses, and paraspinal EMG is normal. Paraspinal EMG will be abnormal in radiculopathies. And so radiculopathies we have to perform the paraspinal EMG, where the snaps are normal, variable late responses. Paraspinal EMG is abnormal, difficult to localize to one route only, usually. So we can have a broad idea on EMG. So radiculopathy, we have shown this diagram earlier. So I've skipped this and go back to the question. A 20-year-old suffers road traffic accidents and reports acute onset of the right thigh weakness and sensory loss in his right leg. Examination shows grade 3 power in the right hip flexion with sensory loss over the medial aspect of his leg and an absent right patellar reflex. Paraspinal EMG would be normal. Is it correct or incorrect? Somebody can tell. Unmute yourself and tell the answer. Paraspinal EMG in this case will be normal or abnormal. Is it abnormal or normal? Normal. EMG would be normal. That's correct. Excellent. So why it will be? Because it's not a radiculopathy. The paraspinal EMG will be abnormal only in the radiculopathies. A man receives IM injection, his left hip, and experiences acute onset of a left flail foot with pain radiating down this extremity. The left ankle reflex is absent, as is the left hitch reflex. The left sural and fibular snaps are also absent. See, needle EMG of the gluteus medius would be normal. Is it true or false? Look, what is the gluteus medius supplied, and what it does? It does is abduction. Supplied by L5. So what will happen to the? It will be normal. Okay. And I muted everybody. Then who is coming back? Good stage. Right. False. Somebody said correctly. It's false. Okay. So an individual develops progressive painless weakness in the right lower limb, right flail foot or foot drop, and absent right ankle jerk. The CP and PT, that is fibular and tibial stimulation, showed no CMAP. The right side snap is normal. Needle EMG demonstrates widespread denervation in both the lower extremities, the lumbosacral, paraspinal, and mid-thoracic paraspinals. Is this a radiculopathy? True or false? Is it a radiculopathy? Somebody has to answer. Is it a radiculopathy?
False.
It's false. Why it's not a radiculopathy? What is it?
There is pain, so radiculopathy. There should be pain in radiculopathy.
No, what is this then?
Root.
See, the snap is normal.
Root lesion.
It's not a root lesion. Root lesion is radiculopathy.
No, not root lesion.
Then what is it then? You have to unmute yourself and talk because so many people are talking. Okay. Or you can write in the chat.
This is ALS.
That's correct. This is anti-horn cell. This abnormality is anti-horn cell abnormality. That's why you are not seeing. It's not a radiculopathy. An individual this 75-year-old develops acute onset of severe pain in the left posterior thigh, followed by a flat foot. Clinical evaluation shows absent left ankle jerk. His EMG 3 weeks later showed absent snap, absent left superficial peroneal snap, which we do, absent posterior tibial CMAP, and common peroneal CMAP. Both are lost. EMG showed spontaneous activity in the left adductor magnus, left short head of biceps femoris, and left tibialis anterior. The correct diagnosis is sciatic mononeuropathy, S1 radiculopathy, lower lumbosacral plexopathy, motor neuron disease. Now, this is a tricky question. 75-year-old develops acute onset of severe pain in the left posterior thigh, followed by a flat foot. Clinical evaluation shows.
Sciatic mononeuropathy, sir.
Why?
Sir, short head of biceps is
Hmm.
supplied by common peroneal nerve, sir.
All right, that's correct. And what about left adductor magnus? That is the adductor magnus has got a dual supply. So you are
Okay, sir.
correct. The correct diagnosis is sciatic mononeuropathy. It is a monomelic disorder and NCV absent snaps. So radiculopathy and MND are excluded because other snaps are normal. No antecedent history of trauma or cancer. So though snaps can be absent here also, these are excluded. EMG showed spontaneous activity in adductor magnus, supplied by both obturator nerve and sciatic nerve, and also by L2, 3, and 4. The correct diagnosis is sciatic mononeuropathy. Excellent. Which of the following electrodiagnostic findings will differentiate L5 radiculopathy from common peroneal nerve neuropathy? Lower CMAP amplitude of common the peroneal or fibular nerve, absent H reflex. Fibrillation potentials in the tibialis posterior muscle, lower snap magnitude, sural snap magnitude.
Fibrillation potential in tibialis posterior because that will be supplied by L5, but not by common peroneal.
Okay, excellent. Right. So fibrillation potential in the tibialis posterior muscle, which is following that. Low CMAP can be seen in both conditions. L5 root supplies fibers to foot dorsiflexors, everters, and toe extensors through the common peroneal nerve. H reflex is the electrodiagnostic equivalent of the ankle jerk. So it will be normal in both CP neuropathy and L5 radiculopathy because there is no L5 reflex. Sural snap divides into two parts that join the tibial and peroneal portions of the sciatic nerve. So it would be spared in both these diagnoses. You can see that the L5 radiculopathy and peroneal neuropathy because the sural nerve divides into two parts when it is getting impulses from periphery and that join the tibial and peroneal portion of the sciatic nerve. So it would be spared in both these diagnoses. Spontaneous activity in the tibialis posterior nervated by the tibial nerve may be observed in L5 radiculopathy, but not in common peroneal nerve neuropathy. That's what the answer somebody gave. Okay, right sciatic mononeuropathy. Which of the following findings are observed? FIPS and positive shock waves in the right gluteus maximus muscle. Absent right hitch reflex. Absent right saphenous snap. FIPS and positive shock waves in the right L5 paraspinal muscle.
Absent right H.
Right. Why it's not the right saphenous snap?
No, saphenous nerve. Saphenous will be supplied by this nerve, the femoral.
It's a terminal branch of the femoral nerve. Correct.
Yes.
Why FIPS and positive shock waves in right L5 paraspinal muscles?
No, because that will be the root, means it is beyond that. So,
Right.
yeah.
How will you diagnose gluteus maximus? How will you support FIPS and positive shock waves?
No, supplied by inferior gluteal, which arises directly from the plexus. So
No,
it is on the
roots. It's
right.
not from plexus, roots. It's from
From
the
the roots,
roots. So it is called root collateral nerve. So the two root collateral nerves are superior gluteal and the inferior gluteal. Both are very important nerves. So gluteus medius is supplied by superior gluteal nerve, not a branch of sciatic nerve. Saphenous nerve is the terminal branch of the femoral nerve, hence not affected. Fifth and positive short waves in paraspinal is in the lumbosacral radiculopathy and will be normal in sciatic neuropathy. H reflex, which is recorded from the gastrocnemius and soleus complex. Monosynaptic reflex with sensory afferents that travel rostrally in the sciatic nerve. Its tibial division to the target muscle. So abnormal H reflex could be seen in a sciatic mononeuropathy. Abnormal H reflex, S1 radiculopathy and sciatic mononeuropathy. See, both these are exam questions. One is a foot drop and a H reflex. Both can be asked in the exam. 10th question. 50-year-old, 188 centimeter tall individual develops pain in the left lower extremity, followed by left foot plantar flexion weakness. Plantar flexion weakness. Clinical evaluation showed grade 4 power in the plantar flexion, loss of pinprick sensation of the lateral aspect of the left foot, and absent ankle jerk. What is the working diagnosis you can think of? Sciatic mononeuropathy, L5 radiculopathy, left upper lumbar plexopathy, lower lumbar plexopathy, S1 radiculopathy. What do you think is there?
Could be left S1 radiculopathy.
S1 radiculopathy.
S1 radiculopathy, right? So can we substantiate why it is S1 radiculopathy?
So the distribution of sensory loss is in typical distribution, and
S1
S1
distribution. Yeah.
yes, S1 distribution, and
Hmm.
this plantar flexion by the tibial nerve. So S1 is one of the components, and it is grade 4 power. So
Which
that can
muscles are doing plantar flexion?
plantar flexion will be done by posterior tibial.
Posterior tibial is inversion. Plantar flexion by?
Plantar flexion by this gastrocnemius.
Gastrocnemius soleus, correct. So this is a left S1 radiculopathy. So now look at the electrophysiological findings to support your diagnosis. Okay, let's have some questions on the electrodiagnosis. The sensory nerve action potentials, left sural, and you can see the latency canal is normal, and left CP is normal. Motor nerve conduction studies, the posterior tibial, the latency is 5.3, amplitude 8.9, conduction velocity, and everything is normal. Okay. The tibial F latency, 55.8, and all these are normal in this case. EMG has, now as I said, EMG is very important. You can see abductor hallucis longus, gastrocnemius, and having gluteus maximus and lumbosacral paraspinals giving fibs and positive short waves, whereas amplitude, duration, recruitment, all are almost normal except these. So that's why in lower limbs, EMG is very important because it doesn't capture nerve conductions, doesn't capture the whole pathology. All sensory and late responses in motor studies are normal. EMG demonstrated spontaneous activity in the several muscles innervated with different nerves as well as paraspinals. Findings are suggestive of S1 radiculopathy. The question 11, 60-year-old known case of hypertension, diabetes 10 years, prior history of L5 radiculopathy was there. He developed pain in the left thigh followed by worsening of his existing left foot drop. The clinical evaluation showed grade 3 power in the left hip flexion, grade 3 thigh adduction, grade 4 in the left foot inversion, eversion, and dorsiflexion. Absent ankle jerk. Is it recurrent L5 radiculopathy, left sciatic mononeuropathy, left lower limb plexopathy, left femoral neuropathy, radiculoplexus neuropathy? Can you come to a conclusion?
This is typical for radiculoplexus neuropathy.
Yes. And I hope everybody else is also following because it is. Can you explain why you think so?
So one is there is already history of L5 radiculopathy, and then he in diabetics this left thigh pain and left foot drop.
Oh,
So foot drop means L5 radiculopathy, it has worsened, and then hip flexion weakness and thigh adduction means there is we have to think of nerves or roots. So nerves, if we implicate, it has to be femoral, then obturator, and then inversion means posterior tibial, and then eversion means peroneal. So many nerves better explained from the plexus.
because of
So
his
that's why.
diabetes, it could be because of diabetic amyotrophy setting in.
Yeah.
That's why there is pain also. So very rarely you get this plexopathy, radiculopathy mixtures. That's in diabetes and trauma. So trauma and the plexopathy has got only two. You have to remember only two: cancer and related issues, radiation and infiltration, or trauma and diabetes. So radiculoplexus neuropathy. Study the electrophysiology study reports and opine whether radiculopathy is suggested. You have to say yes or no. So I'll show you the report. So you look at the sural nerve, common peroneal nerve. That is the sensory nerve conductions. The motor nerve conductions. The question is whether radiculoplexopathy is suggested or not in this case. Is radiculopathy suggested?
Sir, for radiculopathy, we have to also see the radiculopathy, the snaps should be normal.
So
Right?
snaps are available, no? Sural left and right are seen. Though they are low
Left are
amplitude,
reduced.
but reduced. One is normal, one is reduced.
Hmm.
Okay. The amplitudes are of the motor nerve conduction CMAPs are reduced totally.
Reduced.
They are reduced
So
latency. So
radiculopathy we cannot comment alone because they should be normal actually.
Hmm.
In radiculopathy,
Yes.
SNAP and CMAP should be normal.
Okay. So, and what do you think about F wave and H reflex?
So H reflex again suggests S1, probably S1 radiculopathy. It is
Yes.
absent.
Yeah.
Probably it is suggestive of S1 radiculopathy.
And F wave
And
is?
again prolonged. So again suggest yes. Would
So,
be
so what is the now? Do you think plexopathy, radiculopathy mixture is there?
yes, because in
So
plexopathy the
with this
snaps
you
have.
are not sure. With this you are not sure. With this you are sure that both are there.
Yes.
Yes. So it's a mixture. The EMG, EMG is showing fibs and posterior
Then
shock
it may.
waves in all muscles which you can think,
Mm.
isn't it? Though amplitudes and duration, so that it's a diffuse. So that's why it is present. Yes, all sensory and late response are abnormal with asymmetric swirl snaps, low amplitude CMAPs, and prolonged nerve conduction velocity, spontaneous activity in several muscles innervated by the different nerves as well as the paraspinal. So it's a radiculoplexopathy.
Sir, one question in this.
Hmm.
How do we decide which muscles to sample? Like so many muscles are there.
So we have to sample. See, what we usually do in the lower limb is we start with extensor digitorum brevis, right? I'll tell you why we do this. Then we go to tibialis anterior, then medial gastrocnemius, and vastus lateralis. So we have to select one muscle supplied with different roots and different same nerve supplying different muscles. So if you are looking at radiculopathy, same root should be seen supplying muscle supply with different nerves. So that's how you do. That's how you select. Okay, we do medial gastrocnemius and also extensor digitorum brevis and tibialis anterior. So you get different roots and different nerves.
Okay.
So
But
18,
extensor digitorum brevis again is a small muscle. Means is it a good muscle to sample?
yeah, we do. Extensor digitorum brevis, EDB is we can, if you look at the diagram, though it looks flat, you can elicit responses and ask them to lift the toes, extend the toes, you can do the EMG. We usually do regularly. We start with ADV only. So 80-year-old lady, 150 centimeters tall, underwent left hip replacement. 1 week post-surgery, acute onset of pain and weakness in the right thigh. CT abdomen and pelvis are normal. Symptoms have persisted for 1 month. Clinical evaluation showed reduced strength in the right hip flexors and sensory loss on the right medial leg. What lab evaluation is preferred? MRI LS spine, MRI left lumbosacral plexus, repeat CT abdomen and pelvis, electrodiagnostic testing, CSF. Guess. CT abdomen pelvis.
Yes, sir. It's of retroperitoneal hematoma. Then probably repeat imaging.
So actually, this is what you are seeing is a mononeuropathy, isn't it?
Yes, sir.
CT abdomen pelvis are normal.
So this is femoral
Neuropathy.
neuropathy.
So you do electrodiagnostic testing.
Femoral nerve.
Okay, this is because it's only hip flexion and medial part of the leg, right medial leg. So hip flexors and the sensory distribution of the medial part of the leg. That is femoral neuropathy.
So
Okay,
anterior part of the leg also by the femoral nerve only, no, sir?
it is, but the terminal sensory branch of femoral nerve is terminal saphenous nerve.
Mm-hmm.
Isn't it? The anterior part of the thigh, what you are seeing is dermatomal distribution of L234. It is not the nerve distribution.
Mm-hmm.
The nerve distribution is the medial part of the leg. Okay, so electrodiagnostic testing. 80-year-old lady, 157 tall, underwent hip replacement. The electrodiagnostic testing results are shown. Now you can see the same. And what do you think? The sural is absent. Right sural is absent. Absent CP. Radial is normal. Motor nerve conduction studies, low amplitude and conduction velocity is prolonged in the posterior tibial. Left femoral is absent and right femoral is normal. So I think we have already shown. I am just showing the electrophysiology of this case. And
So neuropathy. Huh?
yes, mononeuropathy. The H reflex is absent on both sides. So the EMG, soleus, no fibs. Rectus femoris, vastus lateralis, iliopsoas are showing fibs and posterior sharp waves. These are the muscles supplied by femoral nerve. Paraspinals are normal. Gluteus medius is by the superior gluteal nerve. That's on the post. Rectal longus, tibialis anterior, soleus are not affected at all. So all sensory and late response are abnormal except the right radial snap. The CMAPs are reduced in amplitude and CV prolonged. The femoral snaps are prolonged. Spontaneous activity in several muscles innervated by the right femoral nerve. So diagnosis is right femoral mononeuropathy. Which of the following muscles will indicate root level pathology if paraspinals cannot be examined? Medial gastrocnemius, tensor fasciae lata, sartorius, and abductor magnus. Which of the following muscles indicate root level pathology? You are not able to do paraspinal. Yes, somebody is telling.
Tensor fascia.
Why?
Because it directly comes from the roots. This is L5.
Supplied by what root collateral now?
L5 root.
Superior gluteal. Superior
Superior
gluteus are the gluteus medius and tensor fascia lata.
Okay.
Okay. Superior gluteal now. The concept here is proximal motor nerve. These are the muscles supplied by the nerves that originate before limb nerves originate from the plexus. Gluteal muscles and tensor fascia lata. Inferior gluteal nerve supplies gluteus maximus. Superior gluteal nerve supplies gluteus medius, minimus, and tensor fascia lata. Which of the following electrodiagnostic findings will help in differentiating S1 radiculopathy from sciatic neuropathy? Absent H reflex, absent sural snap, low amplitude CMAP in the posterior tibial, absent saphenous snap.
Sir, absent sural snap, it will be there in sciatic, but not in S1 radiculopathy.
S1 radiculopathy. Okay.
So S1 radiculopathy, sural snap should be normal, but in sciatic neuropathy, it should be affected.
Okay. Why do you say so?
Because S1 radical, because dorsal root ganglia, it is proximal to the dorsal root ganglia. So snaps will be preserved in S1 radiculopathy, but sciatic neuropathy, it will be involved.
Okay. As I said, that snap has got dual, no? It is getting from both. So it's possible that it is the answer, absent sural snap and low amplitude CMAP, absent saphenous snap, sciatic nerve innervates muscles are the posterior thigh. So these are all them. So that's absent sural snap is correct answer. So I think we are coming to an end, but we have a couple of questions more that let's see. And a 6-year-old man known case of diabetes, hypercholesterolemia, developed acute paraplegia and underwent electrophysiology studies 5 weeks later. There is a sensory level at umbilicus, the absent pain and temperature sensations and preserved vibration joint position sense. All the lower limb deep tendon jerks are absent. Normal sural snaps, absent tibial CMAPs, absent F waves and H reflexes. Spontaneous activity in all muscles in the both lower limbs, lumbosacral, paraspinal muscles, and thoracic paraspinal muscles below T9. No recruitable motor units are noted in any muscle exhibiting spontaneous activity. What is the most likely diagnosis in this case?
So this scenario is typical for anterior spinal artery syndrome.
Yes.
Yes, I think you can hit the bull by that. That's correct answer. So the absent HMS are not synonymous with S1 radiculopathies and absent FAs are not pathognomonic of this. So the anterior spinal artery syndrome, the dorsal columns are spared and the anterior horn cells are infarcted and there is Wallerian degeneration of all the motor fibers in the affected territories. Absent F waves, absent H reflexes, widespread spontaneous activity. Well, good answer. Well done. Which of the following muscles is innervated by the sciatic nerve? Gluteus maximus, medius, medial gastrocnemius, rectus femoris, and tensor fascia lata.
Medial gastrocnemius.
Okay, easy answer. I hope others are following. Only you are answering. Medial gastrocnemius. The sciatic nerve is derived from all the 6 lumbosacral roots from L2 to S1. It provides dual innervation along with the obturator nerve to the adductor magnus. It supplies the posterior thigh muscles before it divides into peroneal and tibial nerves. Peroneal nerve supplies the short head of biceps femoris. Then it becomes common peroneal nerve. The common peroneal nerve or fibular nerve as it is called nowadays supplies all the muscles distal to the knee involved in dorsiflexion and eversion. Tibial nerve supplies all the other muscles. A 50-year-old lady with no significant past medical history presents with 2 weeks history of a left foot drop. Grade 4 in foot dorsiflexors, evertors, and invertors. Her reflexes are 2+ symmetric bilaterally. There is a decreased sensation over the anterior part of the left foot. Which of the following diagnosis is correct? I think easy.
L5.
L5 radiculopathy. See, we are putting more questions because these are the questions which I have gone through the papers of various universities. These are most commonly asked and most commonly not answered. So that's why
nice.
stress
Very
more
nice.
so that people will understand, students. Okay. Right. L5 radiculopathy. Next, and we are the same point.
Sir, one question.
Yes.
there is a patient diabetes. He has this features of thigh weakness and sensory loss distribution, but not very clear cut because dermatomes overlap. How do we differentiate between multiple disc prolapse versus lumbosacral plexopathy? Sometimes there is a confusion. So multiple disc versus lumbosacral plexopathy.
See, multiple discs will cause problems if there is lumbar canal stenosis only.
Yes, sir.
Yeah. Otherwise, it doesn't cause that much problem. It's an incidental finding. Unless it
So
is.
there was lumbar canal stenosis also means
Yeah.
significant and with the uh, disc prolapse, and he was also diabetic. So differentiating between lumbosacral plexopathy versus lumbar canal stenosis.
See, lumbar canal
Uh,
stenosis and the disc is a radiculopathy. The snaps are not involved in that.
mhm. But
Only
sir, a problem
plexopathy.
is diabetic patient, no? So again, we cannot really say snaps will be normal because long-standing diabetes, sural snaps will be involved.
Usually, the diabetic hematopathy starts with severe pain, which is burning in quality, not like radicular pain. That
Mhm.
that quality and followed by wasting. Radiculopathy usually doesn't have that much wasting.
Mhm.
There may be weakness because the neighboring nerves supply the muscles, so you don't have that. So
So
it's
we had a patient like this, and we gave him IVIG,
hmm.
um, and he improved dramatically.
So
So,
you have correctly diagnosed it as diabetic amyotrophy.
sir,
Okay. So two questions more. 50-year-old lady with no significant past medical history presents with 2 weeks history of left foot drop, grade 4 strength in the foot dorsiflexor, inverter, reflexes are too symmetric bilaterally. Decreased sensation of the anterior part of the left foot. Which of the following EPS will be seen? What are the findings? Absent snap, absent H reflex, absent sural snap, conduction block across fibular head, spontaneous activity in the lumbar spinal muscles.
should I answer, sir? Again, this is easy only.
Yeah, easy. Bolo?
Spontaneous activity in lumbar paraspine,
That's because of
L5 radiculopathy.
Eric radiculopathy. So, do you do the paraspinals?
Yes, sir, we do.
We do. You are from which hospital?
Sir, that is a secret.
You can tell.
Later on, sir, separately.
Okay. You can message me. Okay. So, which are the following? Right. I think I have given the answer. Terminal branch of the femoral nerve, that I think you all know it's saphenous nerve, right? Femoral nerve originates from the upper portion of the lumbosacral plexus. It supplies the iliopsoas before crossing the inguinal ligament to innervate the quadriceps femoris and other flexors. Use a pure sensory saphenous nerve distal to the knee. Last question. Which of the following diagnosis would be associated with absent sural snaps? Fibular division of the sciatic nerve, mononeuropathy, S1 radiculopathy, sciatic mononeuropathy, tibial division of sciatic nerve mononeuropathy, upper lumbar plexus. Absent sural snap.
Should I answer, sir?
Hmm.
Tibial division of sciatic nerve, mononeuropathy.
Why?
Means sural nerve is a branch from uh, means tibial division only.
No, both it pairs to supply, and when it enters the sciatic, it is getting from both fibular as well as tibial, right?
Mhm.
That is sciatic mononeuropathy.
Okay.
The sural nerve conveys sense information from the lateral aspect of the foot and the ankle. It bifurcates above the knee such that part of it joins the fibular division of the sciatic nerve and the part is the tibial division. The snap amplitude is reduced if either tibial or fibular division is affected in isolation but will not be absent. The sural nerve is connected to the lower lumbosacral plexus. I think you got the point.
Yes, sir. New learning point for me. Thank you.
Right. So, in a patient with the left flail foot, which clinical findings will differentiate S1 radiculopathy from sciatic mononeuropathy? I think this is which clinical finding will differentiate S1 radiculopathy from sciatic mononeuropathy? Absent ankle jerk, sensory loss of the lateral aspect of the foot, weakness of foot dorsiflexion, weakness of hip extension, weakness of foot plantar flexion. Yes.
Yes,
But-
sir.
yeah.
Because hip extension again from the inferior superior
Inferior gluteal now.
now.
Yeah, that was
Biceps,
S1. S1 radiculopathy. The root collateral nerve, inferior gluteal nerve, is from the S1. So we have discussed a lot. Weakness of hip extension. Right. I think that's it. Which are the following nerves originate directly from lumbosacral plexus? Deep peroneal, lateral cutaneous nerve of thigh.
lateral cutaneous nerve of thigh.
Right. Okay. I think this will be, and we'll say bye-bye for
Thank you.
the time being.
Thank you.
Okay, students, any other questions from anybody? Shall we call it a day? And we'll take a break.
Very nice, sir. Please continue. Just a small suggestion, sir. The link is sent means a few minutes before only the session. So if it can be sent 1 to 2 days prior, so we can plan, sir.
Oh, that I think I'll tell. Today it was a bit late in the morning. I sent to the our Sri Hari, but he I think may have sent it late. But next time onwards, we'll take care. Okay,
Thank you, sir.
we'll continue interacting. Thank you. Okay, then it's there on YouTube. You can see. Bye. Good night.